Hello and welcome to Med4Care. I am Dr. Care and today's topic will be anuria. Let's find out together what it is. Anuria identifies a serious clinical condition in which we witness the daily production of urine in very low concentrations, less than 100 milliliters, or even absent. Anuria may represent the further evolution of a state of reduced daily urine production, called oliguria. It can be due to multiple factors such as acute renal failure or, on the contrary, it can occur directly in the last stages of chronic kidney failure, where the patient is completely dependent on hemodialysis. Regardless of the cause, it is of fundamental importance to intervene in a timely manner on the origin of the anuria. Anuria can arise as a result of various causes, some of a systemic nature, others of a more local nature, such as pathologies of the renal parenchyma. Let's take some examples. For example, an anuric state can occur following severe bleeding. If important volumes of blood are lost, the body tries to defend itself from hypovolemic shock by abolishing diuresis and implementing a dramatic saving of liquids. In different ways, an infiltrating tumor that invades the renal parenchyma can cause a destructive effect on the nephrons, the functional units of the kidneys, causing the lack of blood filtration and the final absence of diuresis. Let's now look at the three main groups of causes of anuria, divided according to the type of factor involved. The first group includes the pre-renal causes of anuria, which do not see the kidney itself as responsible for the lack of diuresis, but rather upstream causes, or systemic diseases. Among these we can mention renal hypoperfusion due to hypovolemia resulting from massive bleeding, dehydration, septic shock, diarrhea and vomiting, or heart failure caused by pulmonary embolism or myocardial infarction. The second group presents renal causes which are attributable to direct damage to the renal parenchyma, resulting in filtration deficiency, tubular reabsorption deficiency and failure to eliminate waste substances. Renal causes include various kidney diseases, such as acute glomerulonephritis, acute or interstitial nephritis, or acute tubular necrosis. Finally, the third group sees the post-renal causes as protagonists that include those conditions in which urine is produced normally but, due to a pathological retention mechanism or an obstructive form, it is not emitted until a total lack of diuresis. Post-renal causes include obstructive neoplasm of the urinary tract, benign prostatic hyperplasia, taking certain classes of drugs, proximal or distal obstruction of the ureters. The diagnosis of anuria is based on a practical quantitative approach, simply taking into account the total volume of urine emitted by the patient during the 24 hours of the day. If the volume emitted is less than 100 milliliters, then we speak of anuria. The specialist doctor in charge of evaluating the patient with anuria is the nephrologist or, in cases where there is a suspected urinary retention that can be treated surgically, also the urologist. The first part of the visit focuses on the patient's physiological and pathological medical history, where the latter reports to the doctor all the information regarding any pathologies suffered as well as any conditions to which he has recently undergone, such as exposure to nephrotoxins. After the medical history phase, the doctor proceeds with the physical examination of the patient, making a global assessment of the patient's hydration status and then focusing on the anatomical areas of the urinary tract, where he looks for any obstructions or abnormal masses. The laboratory tests prescribed by the specialist doctor can be conducted both on the blood, where the functionality of the kidney is investigated in a general way, and, at the same time, also on the urine, weighing the chemical and physical parameters. Instrumental tests can prove their validity in ascertaining any obstructive lesions affecting the urinary tract as well as investigating the perfusion status of the renal artery. The most frequently used instrumental tests are renal ultrasound with Doppler, ultrasound of the urinary tract, abdominal pelvic computed tomography. Anuria is a worrying clinical condition that must be managed effectively, thinking step by step and giving priority to those treatments that can stabilize the patient on a hemodynamic level. Proper management of anuria should take place according to these steps. The first provides for a hemodynamic stabilization of the patient with the achievement of a satisfactory mean arterial pressure by resorting to the administration of balanced crystalloids. The second step is a diuretic therapy to evaluate any acute kidney damage in progress. The specialist may deem it appropriate to proceed with a drug therapy with suspension of any drugs with nephrotoxic activity and primary renal metabolism. Finally, an appropriate diet therapy may be considered appropriate with a careful dosage of liquids, electrolytes, and protein requirements. We are now at the end of today's video. We hope you enjoyed it. If you found it useful, please support us with a nice like and subscribe to the channel. See you soon on Med4Care.